Angle this down just a tad. There we go. Love everything about that. Okay, look, I'm going to start this live off by sharing a gift one of my patients got me, and it's pretty amazing. So let me tell you exactly what this gift is. This is something I can't tell you all of the facts about it, but it's essentially a C2. So that's the second bone in the neck. It goes the skull, then C1, C2. This is the C2 bone of a woolly mammoth that is super stinking old, and it's fossilized, and it's pretty awesome. In terms of how old is it, I don't know. I have a card over here somewhere. I think it's either, well, super old. Let's just leave it at that. I don't want to be totally off, but it's pretty cool. And look, these holes here, this is just almost like the exact replica of what it is in the human, just massively big. These are kind of the cartilage end plates where the skull will rotate on. The C1 bone kind of meshed in with this. And then you have the vertebral arteries will go through these holes. The spinal cord goes through here. So it's pretty cool. But this is the C1. Did I say C2 earlier? I was just thinking out loud. Sorry. This is the C1 of it. And it's pretty cool. So I think I said C2 earlier, but it's definitely C1. All right. And then in terms of where is C1 on the model, well, hard to show you on this model. Anyway, that's a little aside. I thought it'd be a kind of fun thing to start with. Maybe threw everyone off. Maybe I should have that model ready to go. But as a reminder to everyone kind of watching from home, my name is Chet Donnelly. I'm a spine surgeon here from Dallas, Texas. I like to jump on these lives maybe for 20 minutes at a time, just kind of answer different spinal stenosis questions, spine surgery questions. Sometimes we have an agenda, and I go over things like fusion surgeries. Sometimes we go over disc replacements. Many times we go over spondylolisthesis, my favorite topic. But this will kind of just keep it live and open, and I'll just try to kind of rapid fire answer people's questions today, and we'll kind of go from there. So I see someone sending gifts. Don't send any gifts. I appreciate it. Don't need any gifts. I'm just doing this just to help educate. So if you're going to send money, send it to people who are like live streaming from Sudan or Darfur and stuff like that. Don't send it to me. I appreciate it. We'll just start off. Great follower here. Been with me forever. Pilly1410. Can you still have an MRI scan after a fusion? Absolutely. Yes, you can. And modern spine surgery, even the stuff we've been using for like the last 30 years at least, the cages, the screws, the rods are all MRI compatible. So it's not the type of metal that rips out and that you can't have an MRI. Now, there is some scatter from the MRI, so you can't perfectly see around the screws sometimes. But truthfully, you usually don't need to see that area. Once it's fused, it's good. A CT would be another way to see around it if you're trying to see that specific area. So we call it a CT myelogram, a little germane to the point. But yep, from Pilly, great question. Yes, you definitely can still have an MRI after a spine fusion, and that's no problem. Another question from Jerry. Desiccated disc on the top of a complete lumbar fusion, the disc between the lumbar and the thoracic. So that's probably referring to is, in terms of the disc between the lumbar and the thoracic, we got cervical spine. We have the 12 bones in the thoracic spine, and then there's 5 bones in the lumbar spine. So it goes L1, lumbar 1, 2, 3, 4, 5, and then thoracic 12, 11, 10, 9, all the way up. So it goes, thoracic 1 through 12. Then after thoracic 12 goes lumbar 1. So it's that disc space right at T12, L1, that you're saying you have some disc degeneration. And that's relatively common because that's a transition zone in the body. Almost like you have a transition zone from the neck, the cervical, to the thoracic spine. There's a lot of stress on that C7, T1 area. That's also a major source of neck pain is the C7, T1 facet joints moving back and forth. The thoracic spine, your rib cage, obviously this isn't a rib cage, but you can imagine a big rib cage around this area. That's kind of a stiff area, and people also auto-fuse that area a lot. So you don't have a crazy amount of motion in your rib cage area. So getting degeneration at a stiff area next to a more motion area like the lumbar spine is quite common. And what to do about it? Well, not a great answer. It kind of just depends. I would also be surprised if your fusion stopped at L1. A lot of times we try not to stop the fusion there because of that exact issue. Zach, what's up, man? Good to talk to you. Jake, I've been having an annular tear for 2 years. I haven't bent over in a year. I'm very strict with movement, everything, but no matter what, it's debilitating. What are my surgical options? It's not healing. Well, Jake, fun disclosure. I can't really give specific medical advice on specific issues, but theoretically and in general, if someone told me they had an annular tear and they couldn't move, they couldn't bend, I would want to get a tad more information because just having like a rip of the disc space, it's almost like getting a cut on your leg. Eventually, that does heal. In fact, you can get an MRI on me or any people in the chat, and probably many people, maybe 30% have annular tears and they're totally asymptomatic. Now, if you're in this chat, you're probably having back pain or else you wouldn't be listening to what I'm saying today, right? But in general, annular tears, I'm not saying they're not painful. They definitely can be painful, but they usually heal, and usually repeat MRIs even show they're there and they're not even painful anymore. So I'm not saying that you're not having pain. I'm just saying maybe there's something else causing your pain. Maybe it's not the annular tear. Maybe you're hyper focused on the annular tear, and yes, it's there, but it probably could be something else, like the muscles in the back, the facet joint in the back, the SI joint. Again, could be the annular tear, but after a year, it shouldn't be the annular tear anymore. It's probably something else. If that helps you or helps someone else, we'll go from there. Another good question from Linda. What does tracer uptake at L5-S1 mean 2 years after lumbar fusion? That's a great question, Linda. Maybe the best one we'll see all day, honestly. Again, not specific to your case, but probably what you're referring to is your surgeon ordered you something called a SPECT CT, SPE-CT-CT. What does that mean? It's like a CT scan where they give you a dye. It's kind of got to go through your body uptakes it. And then if you have cancer, which sometimes that's what you use it for, it might increase in certain bones, like your forearm, different parts of the spine. And it's a way just to see if bones are uptaking the dye that are replicating hyper fast. Well, as a spine surgeon, I'm not necessarily screening for cancer. I have patients that don't know they have cancer and come in, we find cancer. That's not what I'm saying. But sometimes we use that same scan to see if you have something called a non-union. So you get that rod screw spacer, and then it heals, and like you're doing okay, but maybe after 9 months, maybe after a year, maybe after 2 years, there's just micro motion there, and it's just moving microscopically all the time. That's hard to see on an X-ray. It's hard to see on a CT. So a SPECT CT might show increased uptake in that area. It might indicate that you didn't perfectly fuse that one level of the spine. It's a great study. It's one that we weren't using too much. We as the spine community, maybe 15 years ago, 10 years ago, but has really gained a lot of traction. It's one that I even know someone here in the chat is a patient of mine, and we've done it on them, and not confirming or denying any patients here, but they'll probably hear a lot of what I just said to be extraordinarily accurate to them. And, maybe they could reach out to you, Linda, and they can give you their thoughts on that also. Let's see. Will industry will change, hence no talks of stem cells? Okay. I like to answer that question because I always think it's silly. So do I do stem cells? No. Could I go to a weekend course in Palm Beach and get stem cell certified and then have them bring a little spinner to my office, and then I could charge patients $5,000, $10,000 cash starting, November 15th? Yeah, for sure. But, why don't I do that? I'm not totally against it. I guess I like being in the operating room. I like surgery. I'm not against stem cells at all. And if I thought it worked, and I'm happy to, take your money and get you better without surgery, that'd be great, right? I'd be home earlier, have more hair, less radiation to me, could buy a bigger house. But so why don't I do that? Well, one, I like being in the OR. It's fun. But two, there's not great data out there that shows stem cells do anything, in the spine literature at least, that do anything better than a strong anti-inflammatory property without having to use the steroids. So let me say it again. It hasn't been shown to be clinically significant for stem cells to increase disc height, to grow back your disc, to fix your spondylolisthesis, to reverse spinal stenosis. The stem cells don't do that. They do have strong anti-inflammatory properties. You are going to feel better after getting a stem cell shot, usually, just like you're very much usually going to feel better after getting an epidural steroid injection. So I'm not against them because, rats, I can't do surgery. My God, do you know how many 80-year-old patients with terrible comorbidities I have to do surgery for to make the same amount of income from one stem cell shot? So it's not about that. Anyone for real that has like an MD degree, probably without one, could go be a stem cell doctor. So I always think it's funny when people say you're not doing it because you don't want to lose money. It's ignorant and silly to say that because, if I got really motivated and maybe when my neck starts hurting me, my hands start hurting me, I'll go do stem cell stuff and stop operating. Like, who knows? But it's not because of that other thing that people always say. How do you feel about prosthetic disc from Easy? I like them. I like disc replacements in the neck. I'm like mixed on disc replacements in the lower back, but I like them in the neck. There's not an option to do it in the thoracic spine. from Quack Forum, right? I had stem cells in Mexico, but it wasn't localized. It's just more rejuvenating. That's a little different argument. My dad even did that. He got blood taken out, bone marrow, stem cell spun, and then given IV back into him. And he thought it made it feel better. He thought his fingernails grew better. I don't really have an answer for you. It's an anecdotal evidence. That's a different argument. And when I talk about stem cells, I'm talking about putting it out, injecting it right into the disc, injecting it right into the facet. In terms of getting stem cells just put back into you, man, I think that's even more of a little voodoo science there, because I don't know. Just because you can pay money for something doesn't make it better. How about that? How does an epidural shot really work for a herniated disc? Good question from Dana or Diana. I can't see, it's going fast. It doesn't take away that disc material, and I'm definitely a supporter of of epidural steroid shots. But what does it do? It decreases the inflammation of the nerve, decreases the inflammation of the pain, and that's what helps it. And in the meantime, your body kind of eats it away. So is it just a Band-Aid thing from Jess? Kind of. Look, if you said you've had 8 injections, then that's a little different argument. I mean, I'm a little confused by that, because I don't know, a little different argument. And there's different injections. There's RFAs, there's ablations, there's facet injections, and then you also have something totally different. That's for back pain. That's for pain that just sits there at the belt line. Totally different than that is injections of the nerves, something called transforaminal epidural steroid injections, or just a caudal injection. That's kind of injection of the big nerves that have the shooting down the leg. So I think it's good for patients to know before they go, never try injection and just live with the pain, or go down to Mexico for a really expensive shot maybe they don't need. There's, in a way, 2 different types of injections. You got the injections in the joints. That's both in the neck and the lumbar spine. Those are more facet injections. And you got the injections of the nerves. That's better for shooting down pain. So if you have shooting down pain, it's shooting down the leg, and they do like a facet injection, that's probably not the best injection for you. And so when you say you've had 8 injections for back pain, and maybe they're doing caudal injections, or maybe it's like, I've had 8 injections since 2020 and I'm still in pain every now and then. Well, good. You haven't had surgery yet. What's the answer? You just want to go do surgery? Sometimes there's not a great answer. It's hard to reverse time. It's hard to get patients better without doing anything. And so you just kind of have to pick your poison there. Appreciate the likes and the shares. I see those numbers really skyrocketing right now. That really helps promote this to other people. Just kind of reset. And for those that aren't as familiar, I'm Chet Donnelly. I'm a spine surgeon here in my hometown, Dallas, Texas, born right down in downtown Baylor. My family's from here. My wife's from here. Our kids are from here. Actually, technically, one of my kids was born in Florida, because the whole residency traveling around, but we did put Texas soil under his bed, so he counts as a Texan, right? I'm in a 6-person spine surgery group with an office. The offices I go to is Plano and Addison. We also have one in Cedar Hill. One of my best friends, he kind of runs that office. And we do everything from the neck down to the pelvis. This isn't supposed to be like an advertisement thing. This is just kind of, who's this doctor wearing a t-shirt and a sport coat with an American flag behind him randomly on a Sunday. So for those that don't know, that's who I am. And I'll just continue forward now that I've hit kind of the reset button. From this random guy named Zach Davis, who I've never heard the name before, it says, what's better for L5, S1, or L4, disc replacement or fusion? Question is a little confusing in a way, but I guess what's better at L4-5 or L5-S1, a disc replacement or fusion? Neither are better inherently. I would say in general, 80% of spine surgeons are going to tell you a laminectomy or a fusion is better. A disc replacement is an option both at 4-5 and 5-1, but it's a little hairy. And you're like, well, what's hairy about it? Look, I know there's gonna be a lot of haters out there and naysayers in a way, but fusions work when indicated. Fusions work when the right pathology is met. They work. Disc replacements are great in the neck. We love them. In the lumbar spine, they're usually good, but if you have joint arthritis in the back, it might not take away all your issue. If you get loosening of that joint replacement, usually you got to pop that out and do a fusion. That is dangerous, my friend, especially at L4, L5. Your blood vessels run down the front, and having to go in again, and you have to get big exposure, bigger than for a fusion, and like pull those over. I don't know. Those are one of the few elective spine surgeries you might do. You as a spine surgeon might do in a young patient where they could definitely die. So I don't really want to do anything to a patient that could put them at risk of death later on if they have to get something fixed. Whereas, worst case on a fusion that doesn't fuse, which is not great, is an additional fusion. And those are, done thousands of times a week. It's a very well-oiled machine. We know how to fix it. We know how to diagnose it. That's some of the hesitancy on a disc replacement in the lumbar spine for cervical spine. Same argument. If a cervical spine disc fails or something happens to it, dislodges, osteolysis, it's not too hard actually at all. Just go back into the front of the neck, take it out, replace it with another disc, or replace it with a fusion. So that's kind of why there's such a different dichotomy on neck disc replacements and lower back disc replacements. It's kind of like a knee replacement and a hip replacement, where they kind of sound similar, but they're totally different. Okay, and I'll try to do rapid fire questions. Again, appreciate the likes and shares. That really helps promote this people. And thanks for asking questions. Sorry if I'm not getting to them. Again, there's about 2,000 people in all these different chats, and it gets really hard, and things come really fast. So I apologize. From Tuffy Girl, I had a discectomy between 4 or 5 and a ruptured disc. I had excruciating pain. Okay, I don't think there was a question there. I'm just reading them as they come. I am 26. How's the success rate on an ADR from Benny? It's good. I saw in the first thing you said you have a disc herniation. I don't think anyone, hopefully, would recommend a lumbar disc replacement just for a disc herniation. That'd be kind of a nuclear option that hopefully there's some doctors somewhere else. And well, I'll just hold my side comments as I'm on a recorded line. Yeah, that's not a good idea to do. Usually if you have a disc herniation, the best thing to do is drop a tube down. I don't have any here. They kind of look like the size of this thing here. They're not too big, not too small. Make a little pilot hole in the bone if needed, and then just pop out that piece of disc material. That's usually the best way to fix a disc herniation that needs surgery. Okay, I was shot 5 times 28 years ago, and I've been on pain medicine since. Okay, well, thank you so much for that comment. I'm not sure what I should say on that, except for that sounds terrible. Okay, moving on. Kathy says, I have pain post an SI fusion, 4 months. Thoughts? I don't know you. I don't know your case, but I'd say, look, is it the same pain? Is it that maybe your pain wasn't from the SI joint? So how did you get diagnosed with SI joint pain? Because usually if you have SI joint pain, you get an injection, you're totally pain-free, then it comes back, it's probably your SI joint. And then getting SI joint fusion has extraordinarily high success rates. Well, maybe you said you got that injection, it didn't help you. Well, maybe it wasn't ever your SI joint. Hard to say. Maybe your issue was some SI joint, but maybe it's also disc degeneration at L5-S1. Maybe it's also hip arthritis. So those are some of the things I try to check and rule out and maybe your SI joint didn't fuse. Those are some of the things. And 4 months isn't super far out. It's not super short either. Those are some of the things I would kind of look into. Not giving you specific advice. That's how I treat my patients with the same issue. But in general, if you have SI joint issues and SI joint fusion fixes it extraordinarily reliably. From sorry if I'm saying that wrong. It says, hi, I have a bulging disc at 5'1". What is the recommended treatment? In general, 90% of disc herniations don't need surgery. So what is the treatment? Well, if it's symptomatic enough, which if you're asking probably is, it's the course of 3 things. It's buying time, anti-inflammatory, something like Mobic or meloxicam. It could be an epidural steroid injection with a pain management doctor. It could be something called a transforaminal steroid injection, also with one of the interventionalists, calming down the irritation. It could also be physical therapy, strengthening the core muscles, strengthening the hamstrings, strengthening the quadricep muscles are all very helpful. Eliminating things that cause you a lot of pain or activities that cause you a lot of pain, like activity modification. In general, those 3 things. I also am totally supportive of certain chiropractic treatments. Those are 3 to 4 things that really help disc herniation pain, the shooting down numbness and tingling get better. And if those fail, then you can look up something called a minimally invasive microdiscectomy, but that's more indicated for the shooting down numbness and tingling from a pinched nerve from a large disc herniation. People do great. People are surprised I'm saying chiropractic care. Yeah, look, if you're on TikTok, you probably see enough crazy chiropractic doctors out there, but that's not truly representative of all of them. The majority of them are nice, God-fearing people, and they don't drink their own Kool-Aid too much, and they really do normal things. There's some crazy people out there like doing like C1, like a machine that pushes your C1 in. It's just the stupidest stuff I've ever seen in my life. But the overwhelming majority of chiropractors mean well and do a great job. Look, I'm not a fan of neck manipulation. Popping the necks, no way. That's stupid. I don't love popping of the backs, but it's probably okay. Like deep tissue massage, cupping, things like that is all okay in general. I don't like when people say there was just 10 easy payments of $200 to get a certain treatment. That's a little stupid. So do I like chiropractic doctors? Yeah. Do I think they have a role in getting people better without surgery? Yes. Do I have specific recommendations of ones? I do here in the Dallas area, just because I have certain friends with them. I've gotten to know them, got to know their family, and got to know their treatment. Got to get patients get better from them. So you just got to find kind of the right doctor that's a chiropractic doctor to help you. Okay, got into a couple more questions. At C45, there's a broad-based disc. Up, sorry, there's so many questions coming in. These kind of fly by. From flattening the thecal sac. This is from Tanya. Tanya, I would just say, just because you have a disc herniation doesn't mean you need any treatment, but you obviously got an MRI, so maybe you're having an issue. Just having a disc bulge at that area is probably fine. Again, just looking at that report, I don't know anything about you. It sounds like there's not any significant spinal cord compression. It sounds like the nerve tunnels are okay. So it hurts. It's almost like maybe you have a toothpaste container and there's a rip of that toothpaste container being the disc. That hurts, but nothing's come out, which is great. Terrible pain when it's hot. Sorry, when it's cold, pain free when it's hot. I don't know what to tell you on that one. That's pretty interesting. I'm so sorry about that. It sounds very tough. All right, let me get to some of the YouTube questions here. Favorite topic alert. Wish I had a bell. I could ring when someone says the word I love the most. And this is from Eni D81. Interesting name. Maybe I'm butchering that. It says, I have spondylolisthesis at L45. My issue is that if I get off balance, I get pain on the top of my butt. Can that be managed with just exercise? Yeah, probably so. Indications for surgery. I have in many videos. It's limitations with helping out around the house, sexual intercourse, doing laundry, going upstairs, playing with your kids. Activities of daily living are sometimes the indications for surgery. Spondylolisthesis is my favorite thing to treat, just because it's like building a car. There's just, back in like the time when Ford plant was around or whatever, there's just such the same steps every time in terms of the way we do it, that it's very repetitive, very systematic, and very safe. It's like joint replacements these days. It's just the same steps over and over. Super boring for them, but fun for us. But what spondylolisthesis is, these bones slipping back and forth. There's 6 types. I encourage you to go to a certain website. If you got a pen and paper nearby, Eni, maybe I can type it here in the chat. If you have pen and paper, here's a great website to go to that I'm a part of. As my disclosure, because you'll see me right on it. But it's called spondyltreatment.com. Spondyltreatment.com. And I'll tell you a little bit more about spondylolisthesis and some of the things. But look, if you're doing okay, then I'll try to avoid surgery, because many times it's a fusion. If it's a degenerative type and you don't have instability, many times you don't need a fusion, and that's great. Again, appreciate the likes and shares. Just kind of get this around to everyone. Let me see what time it is. Man, daylight savings. This has been the weirdest, longest day ever. All right, it's 4 o'clock. That's weird. I thought it was 5 o'clock. I'll probably go for another 5 minutes here, and then I have to roll, and I appreciate it. Corey's asking, why didn't I become a neurosurgeon? That's easy, because I am normal, handsome, and cool. Moving on the next session. No, I'm just kidding. Honestly, it was something where I liked orthopedics a lot when I was kind of first going through the whole med school process, and you have to kind of pick between ortho and neuro. I wasn't thinking I wanted to be spine surgeon only, which 2 great paths to go through. I was kind of thinking ortho. I liked shoulder. I liked spine. I kind of just wanted to still see, but then also my orthopedic mentors were just kind of a different breed or different caliber. When I was in medical school, they were some of the biggest leaders in the field. They did things really good with instrumentation, really good at fixing scoliosis, especially pediatric scoliosis. And it might just be some of that. Also, I kind of liked, again, this is only a short period of your life, but most neurosurgery programs maybe take 1 resident, 2 resident, maybe 3 residents, when most orthopedic programs take 5 or 6. And you might be like, who cares? It's only residency. Well, I don't know. I was in a fraternity. I like big groups of people, and I kind of liked having a big group of co-residents. So I had a 5 or a 6 person program. So there's 35 of us, and that was kind of great. So I have like these lifelong friends. You lose 5 every year, you get 5 or 6, depending on how big your program is. So I like that aspect of it. I like the idea of going through different fields in orthopedics, having all these different things you'd be good at. Didn't really like the brain. It's interesting. My neurosurgeon friends say that brain surgery is easy. It's the spine surgery that's hard. And some programs of neurosurgery, they don't do much spine. You might be thinking, isn't that neurosurgery? It's brain. They might do a ton of brain and really don't do much elective spine surgery. Or maybe they just have 1 attending, maybe 2 attendings that do spine surgery, and that's kind of it. Well, the nice part about orthopedics is you go to a fellowship. You don't have to, but like everyone does and should. You go to a fellowship, and all of a sudden, you got a whole other group of people you're working with. Great. And you have another 4 or 5 attendings that just do spine surgery. So now all of a sudden, you've had like 7 different spine surgeons teach you instead of just 2 or maybe just 1. You see a whole different way of doing it. Once again, whole different new technology, huge advancers, huge advantages to both. Really, really happy with mine. I'm not, I'm on a recorded line right now. I'm not going to talk trash on the other way. But when I was going through, those were things that were interesting and important to me, is just the variety of mentors I got to have with orthopedics. And that's a big deal. Someone saying, keep my answer short and simple. Yeah, that's probably true, but I don't have any comeback on that one. That's probably true. I should just say I liked it more, but then that'd be boring, right? Someone saying I need an ALIF at 4.5, but I'm scared. Is it a safe surgery? What's the outcome? I heard spine surgery is a coin toss. ALIF at 4.5 is scary. You should be scared of spine surgery. It's a big deal. The outcomes from an ALIF, and I assume they're doing screws in the back also, are extraordinarily successful for the right pathologies. I don't know anything about your pathology. It's very safe. The complication rates are super low. The 50-50 thing is just, it's an old wives' tale. It's just not true. Like, could you imagine if that was true? Like, how would that even make sense? So it's not true. It's something where maybe you can make an argument like a T10 to the pelvis surgery on someone in their 70s or 80s maybe has a 50-50 chance of making them pain-free, because it's like the biggest surgery we do. They're super old. They have comorbidities, a lot of risk factors to pop up. But I think even the big scoliosis surgeons would say, man, it's probably 80-20. And that's my anecdotal evidence on that for sure. So 50-50 is dumb. It's just not true. I mean, it's like I do a micro discectomy on 10 people in a month. Are you saying that like 5 of them do bad? Like, what does that even mean? Like, I'd say at least 9 of them do good. And you're like, well, wait, what about that one? Well, you could still get a little skin infection, a blood clot in the leg, blood clot in the lung, innervating nerve pain, kind of waking back up with. And I'm not saying that makes it a failure surgery, but in terms of like piece of cake, they get surgery, they get better. Yeah, that's the overwhelming majority. But stuff happens. We do big, tough things that no one else can do. And sometimes we get torched for it. But, I'm not going to do a surgery unless I think the patient's going to do good. I'm very busy, and this is my hometown. I have a good reputation. So if I don't think you're going to do good, I'm going to either send you down the street to someone else or just tell you, look, there's no surgery here. And sometimes patients get mad when I tell them that there's no surgery that can be done for them. Or I tell them, look, I don't go to a big enough hospital to do your surgery. You should go see my friend Mike Duffy at TBI. And, if he ever hears this clip, he'd probably laugh at that statement. Hopefully he hears it one day. I don't know if anyone would ever get that to him, but that'd be funny. All right. Well, let me do a couple more things, and I do have to go. Again, appreciate the likes and shares. As a reminder, the spine surgeon here in Dallas. This is my hometown. Born and raised here. I jump on here for about 20 minutes at a time. Usually my kids are napping. This daylight savings is making our nap schedule crazy right now. Naps are few and far between. I did see a comment. It was like, happy SMU beat Miami. I was thrilled. Look, I love Miami. Don't get me wrong. I'm all about the U. But sometimes you got to pick which child you love more in life every now and then. And, we were at the game. We go to a lot of SMU games, and it was awesome. And, truthfully, Miami was so stupid. I don't know if anyone really followed it. I mean, who takes a knee with a timeout left, 25 seconds left in the game on the 25? I mean, did they not watch the Wake Forest game the week before? 2 passes and kick a field goal, they would have beat SMU, but whatever. I don't know if there's any diehard football fans, but they'll be like, yeah, it's so stupid. But at the end of the day, SMU won, and that's all that matters. All right, a couple more things, and I do have to go. I swear this time. Extreme pain upon sitting down, breathtaking pain down the leg from Maris. Maris, I wonder if that's a pinched nerve at L5S1. I'd say get a MRI. Mark, great question. Do you do MIS hemilamies or the traditional open Rothman lamine? Oh my God, I love this question so much. The Rothman laminectomy. God, I've never heard that in my life. I love that so much. Did you teach yourself the tube? Oh, this question gets better. All right, where do I even start with that? So both is the answer. I don't know if I'd call a Rothman laminectomy a big open laminectomy, but I love so much about that question. My MIS training was with Mark Curd and Greg. What's his name? I'm seeing him right now, and he's going to haunt me in my dreams tonight. Greg Anderson. Goodness gracious. Greg Anderson. And we did a lot of tube cases. I did laminectomies through a tube, 3 levels and 4 levels. Knowing what I know now, my God, that is a terribly tough surgery to do a 4-level through a tube. It was just wild that we would do that. Oh, I think I have a kid up. Someone's moving the camera. Uh-oh. Who's moving the camera? All right. Well, on that great question. Oh. No, just wait. Don't go yet. No, I said don't go. Jack, don't go. Okay, well, live TV for you. I just told my kid don't go to his friend's house, but he said thank you and then left. So, okay. Probably got to go. Anyway, great question. Looks like you were a Rothman fellow there. I saw, sorry, a lot was going on there in the background. Okay. I'm going to have to go, everybody. Look, love talking about it. Subscribe and we'll talk again, but family calls and I got to go.